Hey guys, do you work in emergency medicine? An absolutely crazy and intense environment where you see things every single day that most people don't see their entire lifetimes? You feel burned out, unappreciated, like there's nobody you can talk to about the struggles and the things that you see every day? If that's you, I want to let you know that you are not alone. Today I have a bunch of real professionals with real careers in emergency medicine that can relate to the struggles you have on a daily basis. I want you to not just survive working in emergency medicine, but thrive in emergency medicine. My guests are from every walk of emergency medicine, and they're here not because they have it all figured out and they're perfect at this job. It's because they actually have a desire to help you. By the end of this episode, I hope you feel encouraged and feel like you're not alone and realize that you can succeed in emergency medicine regardless of what level of care you provide. My name is Aaron. I'm the host of Practical EMS. I've been an EMT, paramedic, and now ERPA. If that sounds at all of interest to you guys, please stay tuned. I'm going to bring in my guests and we are going to have an awesome show. All right, everybody, so welcome back. We're going to introduce our new guest that has popped in. And what we've been doing, Les, is just saying your first name, credentials, length of time in emergency medicine, and then if you want to start off with an impactful or otherwise story, that would be good.
So my name's Les. I'm an emergency physician. I've been doing this for a long time. I finished med school in 96 and residency in 99. Seen about 130,000 patients. So got a couple under my belt, and pretty much every day I learn something new, right? Just when everyone wants to talk about, oh, you're so great, I know something bad's gonna happen.
Yeah.
So I'm like, no, don't give me any more goat awards, because then something bad happens.
You might have the best radio voice so far.
I can hear it.
I do. I did a little radio.
Okay.
Yeah.
Welcome to Practical EMS.
I have to get rid of the accent, the southern accent.
No, it's endearing.
It's soothing.
Do you have any stories on deck that you want to share?
You know, my favorite stories, and I've got buckets of millions like everyone does, but working nights, always in a trauma center.
Always night shift.
Always the wrong place, always the wrong time. My favorite stories are what I learned from myself and about myself. So super busy night a long time ago. And so busy that I was in the middle of a procedure, a very serious procedure on a patient, and couldn't get it done because I kept getting pulled out of the room for traumas. And I had a patient leaning on the side of the bed for a procedure. I had a medic helping me. And it was so busy, the medic left, and then I came back and the patient was still teetering on the side of the bed asleep. And so it was a busy night. And then in the middle of that busyness, they bring a kid in for maybe non-accidental trauma. It's a little baby who maybe has a toe laceration. Baby screaming, there's 10 other kids in the room, and this is not the parents. The baby was handed off to some other parents, and that's why it's thought to be non-accidental trauma, because this small child can't walk and has a laceration on his foot, right? So thought to be non-accidental, and that's why they brought him to me in the middle of a bunch of traumas and other stuff. And I'm just setting that story up because I'm laughing at myself, but I also want to explain how this all happened. So the not mom is holding the baby's foot, the baby's screaming, there's other kids in the room screaming. I'm like, one of these other ones is gonna fall and break a head, right? At any point, and I'm still running around back and forth from room to room. So we get all the non-accidental trauma stuff set up and finally get into the room to look at the toe laceration. It's so tiny and simple. You wouldn't believe that came back there in the middle. It's less than a centimeter. It's barely bleeding. They're holding pressure on it. So I'm like, okay, we get all the non-accidental stuff. I look at the kid head to toe otherwise, and don't see another scratch on the kid. Everything looks copacetic. Like, okay, this probably was just a little cut from some glass that the kid crawled on. But the not mom is still holding the screaming kid with the toe, other than my little peep that I took. And so I come back in to glue it. It's a nightmare holding the kid down. The other kids are screaming. Literally, one kid is pulling on my pants as I'm trying to glue this other kid's toe. And so I get just a quick look at the toe. I see it. We kind of clean it off real quick. I let a little chlorhexidine dry, and then I'm getting ready to glue it. And I glue it. And when I do, the popper won't work. So I'll have them go get another popper. It won't work. 2 Dermabonds in a row won't work. And it's anxiety provoking with a screaming kid in the room. And you just want to get this done. Everyone wants you to get it done. I finally get the third one and I'm like, okay, it works. I'm just smathering it on there. So I smother it all on there, and looks like it's all sealed over. And then I look, and the 2 toes are stuck together like this, right? So it's on the bottom of the foot. I'm looking at the bottom of the foot, and the kid finally kind of has fallen asleep now, or is being. We had a little sucrose the kid was sucking on, and sweeties, and I'm like, great, I glued the toes together. Okay, I can't do that. So I grab a quick tongue blade just to kind of see if I can pry them apart. They won't pry apart easily. And the kid goes, every time I go to pry. And try the tongue blade. I'm like crazy whining again. I'm like, okay, these 2 toes are just going to have to be glued together because this is ridiculous. I've pulled about 10 times. Every time I go to pull, the kid screams. And I'm like, it's going to be fine. They're glued together. It'll all come off in a week. And we're done. And I got all these other traumas. And so then I just happened to look at the back of the toe after that, and they were fused. The first and second toes were fused. And the point of my story is the Swiss cheese effect is real. You're getting hammered. You're busy. There's no mom there to say, oh, those toes are fused. This is some neighbor lady who has no idea the toes are fused.
Yeah.
I looked at the other toes. They're not fused on the other side when I did head to toe. And the one area I didn't get a great look at was the thing we were holding the pressure on. And I just had to immediately come out and laugh at myself and tell the entire staff that story and kind of break the night down because it was so stressful. Yeah. But it's just one thing after one thing after one thing after one thing kind of leads into something ridiculous. And there was no bad outcome, but that's how things happen.
Yeah.
That's amazing.
That's funny.
And I've been doing this a long time.
Yeah.
I'm the oldest person in that ER every night.
That is amazing. I have to tell the story that I have about Dermabond because it makes me look even worse for sure. This was when I was a pretty new ERPA. I never used Dermabond before. Didn't realize this stuff drips like crazy. And I'm repairing this young girl's eyebrow laceration.
Oh, no.
Doesn't, well reapproximated, really doesn't need stitches. My rationale is this is going to heal better cosmetically. So, I put the Dermabond on her eyebrow and I'm looking away at something else and it drips onto her eyelashes. And her eyelashes get stuck to her cheek and she can't open her eye. And so I'm having to clean I was in there like an hour trying to get this stuff off her poor eyelashes. No point in that story other than to make me look like an idiot, but I definitely did that. Definitely did that.
You're not the only ones.
I've got some other topics to cover. Why don't we give Les the chance to kind of answer what you would tell your younger self or somebody new or somebody just burned out of emergency medicine?
Yeah, I was sitting over in the corner when you guys were answering that question, and there's so many different ways to look at it from, how hard you work and what you do matters and what other things that don't matter. And, we choose the path that we take every day and it does this and that, right? I think it's twofold. I would tell my younger self that all of the work that I've done, all the training, every second of everything that I work on to get better is worth it. Because you never know when that rare occasion comes that you need that tool set that someone else didn't work on and you can do it. And at the same time, a realization I think I'm just coming to after doing this for so long, right? 24 years as an attending, is that some stuff doesn't matter. I've spent my career cranking, being as efficient as I can. And one of the reasons is that patients are waiting. I've got patients out in the waiting room. Someone's hurt, someone's worried, someone's scared. I need this bed empty to get them back. These patients have been waiting for 2 hours. I need to get them home. And no one really appreciates that, right? They get mad when their McDonald's is taking 20 minutes, and they get mad when their rule out for their STEMI takes 2 hours. And that's just the way it is. I was reading a book not long ago about a physician in the 1700s who he was complaining that patients would be sick for 2 weeks, but they were angry at him when he couldn't get there in his horse and carriage in half an hour. So it's never been any different.
It's the
So
same.
funny.
And so I think I would tell my younger self, all the work you do matter. Sometimes the little things matter, but killing yourself for convenience for people and is probably going to go unappreciated. So if you're doing it, you need to do it for your own conscience and not for what you're worried about patients are going to think or feel. You move as fast as you can and you try to be safe.
Yeah.
That's a really good point.
One other topic I want to introduce maybe before our last topic. We have a really good mix of providers here. We have an EMT, we have a couple paramedics, we have a flight paramedic, we've got a nurse, 2 docs, a PA. What would be something that you wish everybody else knew about your particular job? And maybe we can start with Nathan.
Particular job?
Yeah, I mean, just about being an EMT. I mean, what's something that you think maybe we don't know, maybe we don't appreciate, maybe we don't understand is difficult?
Oh, that's easy as shit. That's
Oh, we
easy
can
as
say that.
shit. Being treated like a slave. Being treated like garbage because we have like 3 letters on our arm. You know, being treated that like we're stupid and dumb because we have 3 letters on our arm. Not getting listened to for the same thing, you know? Like, I know EMTs who run circles around medics, you know? I know some smart-ass EMTs, and then whenever something's going on, and then they're like, hey, let's try this. No, go get the bag. Or no, go outside, you know? So in my personal opinion, an EMT basics point of view, I mean, out here, our scope is amazing, you know?
Yeah.
I do have my IV, I know EKGs, I have my ACLS, I have my PALS. But as soon as I sit here, I mean, thankfully the partners I've had, especially my old partner, was my mentor and he treated me like a partner, you know? But some EMTs who have, you know, degrees in biology or degrees in this, and they're educated with a whole bunch of stuff, you know, and they want to help, it gets shut down immediately, you know? So yeah, no, that's too easy. That's that answer.
Yeah. No, I'll comment on that because I have strong opinions about that as well. I mean, some of the partners that I had for years, Joey's one that comes to mind. If you're not using them as a partner and listening to their opinion, you're making a huge mistake as a paramedic, because sometimes paramedics get so focused on a call and you hone in on one differential and you're convinced that's all that's going on. You're missing everything else, especially when you're getting a report from the fire paramedic on scene and they're honing in on one thought. And now you're honed in on that one thought. A second set of eyes and a second opinion on patients is an absolute asset. So I hope that my partners think that I treated them like a partner and not as, you know, just an EMT. But that's a great point.
I've got another aspect of that is that when I came up here from down south, when I got here,
Thank you.
I'd been a medic for about 4 years, and I was busy. There were only 2 of us at one point, so we were running everything, and so anyway, when I got up here, and I've worked with a ton of really great paramedics. I mean, really great ones. Yeah, but my partner, Pete, he was my first partner up here. He's a PA now, actually. But my partner, Pete, was an EMT, and he taught me more about being an effective paramedic than any medic ever taught me. Yeah. Any medic. And, you know, I owe my career to that man. And I hope he doesn't hear this. He won't be able to get out of the room. But yeah, and one of the things he taught me is that EMTs do know what they're doing. And Colorado, in this particular place, our EMTs are better than anywhere I've ever seen. Yeah.
And then, like, I mean, getting like EMTs like to just further knowledge and stuff, because that's like the big difference. Literally is just schooling and college and that kind of thing. But, you know, places have BLS rigs where they do the non-emergent calls. Yeah. So if one, that helps with a lot of confidence with EMTs and stuff, but then that can also help them treat somebody without, you know, having like a medic there.
Yeah.
You know, they can still do patient care. They can still help somebody. Even if they have like a nice understanding of EKGs or even a gist of it, you put them on the monitor, there's elevation and with reciprocation. Yeah. Oh, we have a problem.
Yeah.
You know, do I call an ALS rig or I'm 1 minute at the hospital? I can just go there.
Yeah.
You know, so like it just always annoys me because we're here to do patient care. We're here to help people.
Yeah.
The worst thing that can happen is, you know, ego.
Yeah.
You see what I'm saying? Like that destroys people.
It does.
And that can destroy partnerships and a person kind of thing.
100%. And I have gotten way worse reports from medics that have huge egos than EMTs that have taken the patient seriously.
Yeah. That's true.
Let's hear from our paramedics and see what do you guys want us to know about your jobs? I guess we've kind of answered that to some degree, but do you guys have any other thoughts?
Go ahead. Yes.
I mean, I did a field EMS for several years before going into flight, and I still have an ambulance job that I work PRN that I absolutely love. It's a rural company. I think I was fairly disillusioned with flight. Like I thought like that was kind of like the cream of the crop, the absolute best. But you do find out like in flight in critical care medicine, mistakes happen, you know, a lot. And it's just, I mean, it's working on the truck is hard. Like going into an environment that you know nothing about is really hard. Because even with flight, when we go into scene calls and we fly in, we shut down the highway, you know, even if it's a little rural volunteer system that doesn't have ALS, like they do a lot of care before we get there and they've got great input. So we're kind of like, we're not really first responders anymore, you know? So there's a lot more challenges, like in my opinion, in EMS than there is in flying in critical care that people don't really realize. But I'd say anybody going into critical care, be patient with yourself because it's overwhelming. I mean, you do learn a lot more. Your scope is advanced. I mean, but you know, be kind to yourself, be compassionate to yourself included, and just kind of take things slow and learn from everybody, you know, just because once you get that flight suit on, sometimes people think that they are untouchable. That is not the case at all. Like I am so appreciative of my volunteer, you know, first responders that don't even have IV cert or whatever. They give great information. They care. I mean, these people do these, go on these calls and they're not getting paid for it, you know?
Yeah.
And they have no resources, which is way more terrifying than being in the helicopter with my ventilator and like I've got everything at my disposal. I can put in chest tubes and it's like going out into an unknown situation and they don't have a lot of the equipment. I mean, and they do a fantastic job. So it's definitely stay humble, like, you know, and be appreciative of how you got to that point for sure.
Yeah, for sure. I think there's people in this room that have seen Emergency before on TV.
What are you talking about?
That used to be a training. We used to use those training films, but you know, Gage and DeSoto. But they actually showed us in a way that showed that we did not only the emergency gee whiz stuff, but we also did the like get the kid's arm out of the pool drain thing kind of deal, you know, that was not. But then along the line, I think one of my bitches is that we're if we're depicted in some sort of media, a movie, TV show or whatever, they either show us as really stupid, you know, we're the redheaded stepchild of the EMS.
Careful.
No, you do have a little. Yeah, you're a little. Yeah, so, you know what I mean. And or they show us as every call is
an emergency.
Is just helmet fire. You know, I mean, you're using every tool. You know, you're using the laryngoscope and the Hearst tool all at the same time. You know, and. So, what was that one with William Shatner that they would have stories, Emergency 911, and they would have true stories that they would show, and everybody was a save. Everybody was a save. everybody was a save.
Yeah.
And they're not like that, and it's a lot of pressure to work under those, kind of things. And I think so. I think what I would want people to know is, we're not stupid. We're really well trained. I had the honor of being trained by a cardiologist. So in paramedic school, he's the guy that brought paramedic to Colorado. And so, but he was a cardiologist that had given up his cardiology practice to do emergency medicine.
Oh,
and a war hero, by the way, World War II. But anyway, I'm one of Jerry's kids. And so I learned all those things, even though I only had a 2-lead, life pack.
Yeah.
We had to move the wires around to change the leads, literally. But it made me learn, what my vectors and stuff were. But he had the foresight of saying, knowing that we were going to have 12-lead machines in the field. And so he taught us to read the 12-lead, not just rhythms, but, recognizing MIs and WPW and left bundle, right bundle, anterior vesicular block, the whole thing, So we're not stupid. We're actually pretty smart, some of us. But we're not always doing those gee whiz things either, and realize that we make mistakes. Not everybody lives, so.
All of this stuff that anybody hears today is just our opinion only. It does not reflect any agencies we work for, hospitals we work for, any companies we work for. It's just our opinions only. Like I said earlier, we've modified all these patient stories so that any resemblance to a real life patient is just coincidental. This is for educational and entertainment purposes only. There is no medical advice here, so do not use this as medical advice. Do not use this to diagnose any medical or healthcare related conditions.
And we don't shock asystole like you see on TV all the time.
We used to.
Yeah, used to. I heard about that.
Well, we did. And I'll tell you why. You want to know why?
Yeah, no,
I'll tell you
gladly.
the story. So a guy named Gordon Huey,
Okay.
he was a professor at University of Arizona. He did a study, and this is back because now when we put a monitor on, it comes up in 2 leads, right?
Yeah.
Wasn't like that before. When we put somebody on a monitor, you looked at 1 lead. So we would shock asystole, and sometimes it would work. And the reason was
No shit.
is because, so asystole or VFib, it's cyclic and it travels like this.
Yeah.
And so if you're looking at a lead, so say you're looking at lead 2, right? And if where it is now is perpendicular to that lead, it's going to show what? Isoelectricity, asystole, right? So you wait a few minutes and you'll see it. But that's why we started to do, we'd see one, if we had somebody in asystole, we put them on the monitor. Well, we'd switch the leads and see what,
If there was
we'd
any
look at lead
electrical
1
activity.
and then we'd look at lead 3,
Yeah.
to
see if there was
and,
any
and lead
activity.
1, they might be like this, but in lead 3, they may be like this,
Yeah.
So we would
Is there
shock
a-
asystole because sometimes it would work, but it wasn't really asystole. It was really VFib.
Yeah.
Depending on
Is
what
there a-
road you're traveling down too.
Yeah.
I probably shocked asystole a lot.
Fairly harmless as far as I'm aware.
Yeah, it is.
Yeah.
Dad's dad.
That is kind of
Yeah.
Can't make him any worse.
Yeah. Gonna make your dad hurt.
Kira, what do you got from the nursing perspective?
Oh gosh. I think probably one of your biggest jobs as a nurse is like to advocate for your patient. And
yeah.
that can be very time consuming, very exhausting. You can hit a lot of brick walls sometimes with that. So
Brick wall physicians or
yeah,
PAs,
yeah,
sorry. There's
yeah.
PAs.
Oh, very much so. I mean, all of you, I work with all of you, and it's like you guys are amazing. You care about what the nurses say, but
Stop.
but I can remember a specific instance with a ER provider that this patient came in. She was a little bit off her rocker, on some drugs, whatever. The provider looked at that and didn't feel that it was necessary to do a very thorough assessment. And I did. And I'm palpating her chest. And I'm like, there's a definite deformity in her sternum. That's pretty uncommon. And she was an assault patient. but she's so hard to follow, can't tell her story in any sort of like clear way. But I was like, I know this is wrong. So I go to that provider. I'm like, hey, can you please order a chest x-ray? There's definitely something wrong. And this provider completely blew me off and was like, that is not true. I'm not doing that. You're feeling wrong, essentially.
Yeah.
And that was very discouraging to me. So I pushed. It is bad medicine.
Yeah.
So I pushed back really hard and I said, I'm telling you, you didn't take the time. When I palpated, the patient was in pain. I could tell that this is wrong. I'm going to order a chest x-ray.
Yeah.
And ended up getting the chest x-ray and there was a fracture. And so the provider had to order a CT chest and huge sternal fracture, had to admit her for all that stuff. And so that provider was humble enough to then apologize and was like, I'm so sorry. Like, you were right and you saved my butt in that. And like, I won't not listen to you again. But it's hard that it like takes something like that for a provider to listen. But yeah, it's super important to advocate for your patients and to not give up, because that could have been really detrimental for this patient if that wasn't identified. And anyways, so I think being a patient advocate is huge. And for patients and their families, like especially in the emergency department, it's so important to be kind to your nurses. I know there's been a lot more awareness of that now with COVID and everything, but you spend a lot of time in your patient rooms. You give a lot of yourself to one patient, and then you have to compartmentalize and go focus something else to a different patient. So being kind and being understanding that your nurse does care. She wants to be in your room, but you just can't at this moment. There's a good reason most of the time.
Yeah, I think that's a great point. I haven't been doing this very long, but if a nurse has a concern about a patient, I try to tell all the newbies, like, you need to get off your butt and go reassess them, especially the ones that are admitted that have been sitting in the ER for hours. The nurses are still in there checking on them and their conditions change. So I think that's a solid point. Guys, I'm going to jump in here. That's the end of this episode, but we're going to continue this discussion with these same fine folks next week. So I hope you'll tune in. If you guys found this valuable, if you were encouraged by it, uplifted by it, or if it just makes it so you don't feel like you're so alone with the stuff that you have to struggle with every day, I hope you will go over to practicalems.com, join the email list for more encouraging and valuable information. I'll send you emails to let you know when the new content comes out. And of course, if you subscribe on your favorite podcast player, leave a 5-star rating and review. That is super helpful to allow me to do this. I don't make any money off of it, and it does cost money to produce. So the more you can subscribe and participate, the better I am able to continue producing this. Thanks again, guys, for tuning in. I hope you enjoyed the show, and we'll see you next week.